You so IT techie. You're techie in everything. It's the grace of God. So this is getting ready. I think we're live and ready. Good evening, everyone. Welcome to Medical Mondays with Dr. O. Welcome to another fascinating episode. So, I am Toyin Okwesomi, a family practitioner, HIV specialist, and I treat addictions in Maryland. I enjoy Medical Mondays because I learned so much. We all learn so much on this platform, and we have the opportunity to share, to just learn together. Tonight, I want to thank Dr. Ajagbe for stepping in for me when the speaker we had scheduled today had some emergencies and could not make it. So Dr. Ajagbe is going to talk to us about a subject that I've received text messages about that it was a typo. It was not a typo. The title of tonight's talk is Where Your Tongue Is Matters. So when you look at it, it looks like it should read where your tongue matters, but it's actually where your tongue is matters. So over to you, Dr. Ajagbe. Thank you, sir.
Good evening, everyone. I'm glad to be here again to share some light on an area that most people probably never even thought about. But it's an emerging area of dentistry, and many dentists are not aware of this. And so, but I think you will get some information, valuable information from the presentation tonight. And yes, the title may seem very awkward when you first see it. It'd be like, wow, it doesn't make sense. But if you read it slowly, it's simple. It says, where your tongue is matters. Now, many times we don't even pay attention to where our tongue is. We just assume that our tongue is in the mouth and it's in the right position, right? But many times our tongue may be in the wrong position, and that is why many people have issues with talking, swallowing, chewing. Even the use of the tongue can become very awkward for many people. And they may assume that it is normal for them because they didn't know any different, anything different than that. They were, born. So, but I'm going to shed some light on the positioning of the tongue, and we can address it together. And if there are questions, we'll be able to address those questions interactively. So, when most people think about oral health, they tend to focus on teeth, gums, bad breath, and, just aesthetics, the spaces between the front teeth and so on. But you need to know that there's much more to oral health than that. In fact, the position of your tongue and the way you breathe, the way you swallow, and the way you speak can have a significant impact on your overall health and well-being. So today, I'd like to share with you some insights into the myofunctional approach to oral health and how it can help improve your airway health and then overall wellness. So you hear the term myofunctional, and then you say, "Ooh, this is a big word. What does that mean?" Myo means muscle. Functional means function, just myofunctional. So when we apply it to the mouth, we're applying it to how the muscles of the tongue actually function. So the first question you want to ask yourself is, so what is this myofunctional therapy? What is this? All right, well, myofunctional therapy is a type of exercise therapy. So it's kind of like something that a physical therapist or um, uh, occupational therapist or speech therapist should know how to do. But most of the time, their curriculum does not include some of these things that are included in myofunctional therapy. And that's why it's a separate discipline on its own. Now, myofunctional therapy is a discipline that is utilized in conjunction with airway dentistry in order to make the life of an individual to be much better. So now myofunctional therapy looks at first of all, we have to evaluate the individual and know where does the person's tongue lie at rest. I think the last time I spoke, I kind of mentioned that briefly, but today, since we are focusing more on that, I want everybody who is hearing my voice to take a few seconds as you listen. Dr. O is already doing it inadvertently, sipping something. I want you to kind of, if you want, you can close your eyes so you can at least visualize where your tongue is. Visualize where your tongue is when you are not doing anything. You can close your eyes for a few seconds. If your tongue is not resting on the roof of your mouth, with the tip of your tongue slightly behind the front teeth, then your tongue may be in the wrong place. So if you do that and you find out that your tongue is not in the right place, take a note of that. And then when you swallow your saliva, kind of visualize how your tongue moves when you swallow your saliva. Now, if you have a cup of fluids, whether it's water, coffee, tea, whatever, try and take a sip and see how you swallow. Well, most of the time we take these things for granted. We assume, oh yeah, everything is fine, until we find out that how we've been doing it is wrong. Okay? So the goal of my functional therapy is to actually retrain the muscles of the mouth, not just the tongue in this case, the muscles of the lips, the muscles of the cheek, and then the muscles of the tongue, as well as the muscles of the soft palate, that is the roof of the mouth in the back. So this can help improve. Once this is done, when the muscles of the mouth are retrained in the proper way of functioning, this can help improve the overall oral function, that is how the mouth works comprehensively, and the airway health, and reduces snoring in many people, because many people snore because their tongue is always in the wrong position. And if the tongue is actually tied to the floor of the mouth, it may actually, when the patient is sleeping, can fall to the back and block the airway. And so that's what we call the sleep apnea. And sometimes, so we have to prevent anything that will block the airway, whether the patient is sleeping or awake. Now, what are the common signs of oral dysfunction? That is, when we say that there is a problem with the muscles of the tongue, and we say there is an airway issue, what are some of the things that we observe or we look for in that individual? The first one that you'll be thinking we will be looking for is the mouth breathing. How is this individual breathing? Is the person breathing through the nose or through the mouth? If the person is breathing through the mouth, we want to find out why. Is it a habitual mouth breathing, or is it because the two nostrils are blocked? If the two nostrils are not blocked, does it mean that there's something in the back of the nose that is closing the airway so air cannot go through. And that's what is called upper airway restriction. And that is a serious problem for many patients. So mouth breathing is the first thing that we look for in assessing the airway of an individual. The next thing is snoring. Snoring, some people would know that they snore, some don't know that they snore until somebody else tells them that, oh yeah, you were snoring a few minutes ago. Your head went down and then you started snoring. Oh, wow, I didn't know I was snoring. I'm so sorry. Wow, I didn't know. Anyway, sometimes that's the only way some people would know. Other times, some people will actually hear themselves snoring and say, wow, is that me snoring? Well, just about the time they're about to wake up. Then sleep apnea, we've talked about that less during the course of Medical Mondays. Sleep apnea is just a condition where somebody's breathing while they sleep stops several times during the time of sleep. And that is a very troublesome situation, in which case the patient doesn't get enough oxygen, to oxygenate the brain and other parts of the body. And that causes a lot of problems, including chronic systemic conditions like blood pressure, high blood pressure, diabetes, obesity, and all these kind of problems that are associated with chronic disorders. Grinding and clenching of the teeth may be the first sign that is observed in some individuals that are having airway problem. And I think I've explained this before, and I will explain it again today. When somebody stops breathing several times at night, the brain actually arouses the person without making them to be completely alert. They are slightly awoken to the point where they can move the tongue forward from blocking the airway. And the involuntary action causes them to grind their teeth. Now, the first thing that happens before they grind their teeth is when they stop breathing and there is oxygen shortage to the brain. When the oxygen concentration in the blood falls below 80%, the patient will go into what is called the flight, fright, or fight mode, which is a state of anxiety. And that causes the blood pressure to go up transiently. And then everything will move the body in order to alleviate that issue, which is to increase the oxygen that is going into the lungs and eventually going into the body. And the only way to do that, if there is an obstruction, is for the lower jaw to be moved forward. And if the lower jaw is moved forward, the teeth will grind against each other, and then the patient falls back asleep, and then the patient is woken up again when they stop breathing. You can imagine a patient that stops breathing up to about 20 times per hour. If they slept for 8 hours, 20 times 8 is a lot of time to be stopped. To have stopped breathing and started breathing all over again. That's like 160 times. And most of the time when the patient wakes up, they're very disoriented. Many of them will wake up with headaches, with jaw pain, with anxiety, feeling they are very unhappy. And most of them during the day, they have excessive daytime sleepiness. All right. So the other thing that could be a presentation in this kind of situation is jaw pain and clicking of the joints that we call TMJ dysfunction. So some patients, that's all they will be complaining of, in addition to headaches, of course. And then every time they try to chew, they have jaw pain, and their jaw, the joints clicks all the time. When they yawn, sometimes their jaw locks, and then we call it TMJ dislocation. We've talked about headaches in passing, but headaches are common among the people that have this problem. with, myodysfunction, if you want to call it that. That is, the muscles of the mouth are not functioning properly, which is affecting the jaws and the joints of the jaws, and eventually causing patients to have headaches. Some patients will have neck pains or shoulder pains or a combination of all of this. And we've seen people who have problems with talking, which we call speech impairment or speech difficulty. Now, if anyone experiences any of these symptoms, it is important to speak with, a dentist. If you have a dentist, call your dentist or go for a visit where you go for your regular visit and make a complaint. Add that to your chief complaint that, doc, my jaw always clicks, either when I'm yawning or when I'm chewing or when I'm eating. When I wake up, my jaw hurts and I have a headache. The root cause of that will be easily evaluated. If you don't have a dentist, if you go to your primary care physician, you lodge the same complaint, they will evaluate you as well to figure out what the underlying cause is. Now, if the underlying cause is visible, it's clear, and the person and you need to be referred to a dentist, your primary care physician will be able to do that. And if you report to your dentist first, of course, the dentist will evaluate it and propose a treatment plan that will alleviate you the problem. So now let's talk about the myofunctional approach to oral function and airway health. So the approach actually deals with, how to address all of these individual, problems. What we want to do is to correct the posture of the tongue, because we don't know that the tongue has a posture until you are alerted to how your tongue is. I'm sure you've seen some people when they are sitting down and they are not doing anything, their tongue is hanging out of their mouth. The Yorubas will give them derogatory name like, de. Look at this one, like somebody who is a dumb, a dense, with a tongue hanging out of their mouths, that they can't control their tongue. But many times it's just because it's an anatomical defect. And some of these people need help, and they need to be, such problems need to be addressed. We want to improve breathing. That's one of the most important things that we want to accomplish when we try to do the myofunctional therapy. We want to make sure that the airway is constantly open. And not only just open, we want to make sure that patients are breathing through their nose and not through their mouth. So if a patient comes in with a mouth, breathing, we know there is a big problem with that, because anyone who is a mouth breather will have consistently dry mouth, will have increased plaque accumulation, which is the stuff that causes cavity and gum disease. And then, of course, they will have bad breath. So, and what we are doing is try to not just improve the airway, but also to prevent all these the oral diseases. We also want to improve swallowing. We assume that swallowing is a no-brainer. Everybody can swallow, but I can assure you that there are lots of people that are not able to swallow properly. They don't know anything different until somebody diagnoses their problem and tries to help them and retrain them on how to swallow. When somebody swallows wrong, there are some conditions that are very mind-boggling. What we call reverse swallowing? Many people have never heard of it before. Reverse swallowing is such that you put some food in your mouth. Instead of the food going into the esophagus, which is the tube that takes the food to the stomach, the food is pushed to the nose. So many times these individuals are choking from their food. Many times they actually develop, because of the backflow of such abnormal swallowing pattern. They will have aspiration, that is, things will go into their lungs, and they may eventually have lung infection and all of that stuff. The other thing we want to accomplish with a myofunctional approach is correct speech. We want people to be able to speak properly. There are many people who cannot pronounce R, for instance. Some people cannot pronounce R. You ask them to pronounce R, they will say, ow, 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 ow. Say, oh, no, I said R. No, say, ow, 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 ow. Okay, well, it may not be because they don't want to speak properly. It's just because there may be an anatomical problem. Many times the people that have what we call the tongue tie are the ones that have problems pronouncing many of these words that require the movement of the tongue. So those are the basic things that we want to incorporate in what we call the myofunctional therapy. Now, how about the airway dental interventions? The airway dental intervention is just addressing the dental treatments with the mindset that the airway cannot be allowed to be compromised. So if somebody has very narrow roof of the mouth, for instance, a roof of the mouth that is very narrow and very deep, we know definitely their tongue cannot occupy that such space. So we must help them to open up their airway. And since the floor of the nose is the top of the roof of the mouth, anything you do to the mouth, to the upper jaw, will affect the nose. So many of these people that have such abnormality, their nostrils are very small, and most of the time their nostrils are completely blocked. So these are the people that are constantly, by default, mouth breathers. They cannot do anything else until that nose is taken care of. So such patients will always have problems with their throats, because the air that is going through is not filtered, is not purified, which is what you get as benefits from air going through the nose. The nitric oxide that opens up the little blood vessels are not, would not be added to the air going through the mouth, and so the lungs is not operating optimally. So we must help airway, and part of the airway management, to open up the nostrils. Once the nostrils are open and the patient can breathe properly through the nose, normal breathing is silent. When you breathe through your nose, it is silent. It should be invisible. If your breathing is becoming visible and is becoming audible, then there is a restriction somewhere. If your nose is partially blocked, you know how your breathing will sound. So we must address that when we approach any treatment using the airway intervention. So some of the things that we do as dentists will be to use orthodontic appliances, either with an expander. An expander can expand the upper jaw to the point where the jaw will actually grow in 3 dimensions. So we can gain volume. And as the upper jaw is grown, the lower jaw also follows. And not only that, the nose also follows, because everything centers around the upper jaw. If the upper jaw is restricted, the lower jaw will be trapped in the back, closer to the neck and closer to the throat. And that is why most of the time, those who have very small lower jaws have problem with breathing. So the other thing we want to make sure is using any other appliance, like biomimetics, which I think I've shared on a very few occasions on this on Medical Mondays. So we can use all these devices. Another device that we could use, if all the problem that is there is just to move the jaw forward, we call it the mandibular advancement devices. And that is something that can be held at a particular location so the jaw cannot fall back when the patient is sleeping. All right, so let me kind of just share 2 case studies. Well, I would like to share with you some real life examples of people who have benefited from myofunctional therapy and airway dental intervention. So the first patient is an adult who has struggled with snoring and sleep apnea for years, who underwent myofunctional therapy and orthodontic intervention and experienced, after about 18 months of treatment, this individual experienced a significant improvement in his sleep quality and overall health. Another patient, patient number 2, is a young patient with speech difficulty and poor oral function. This child also underwent myofunctional therapy and orthodontic intervention and saw significant improvement in her speech as well as the airway and oral overall health. So now, in conclusion, let me just round up by saying where your tongue is really matters. And the myofunctional approach and airway dental intervention can help improve your oral function and airway health. That will reduce the risk of snoring and sleep apnea, and it will enhance your overall well-being. So by incorporating these principles of myofunctional therapy into our daily routine and working with dentists and other healthcare providers, we can explore dental interventions that can improve the airway health as well as achieve optimal function of the mouth muscles, and the airway will be kept healthy. Thank you.
Thank you so much, Dr. Ajagbe. Again, thank you for stepping in at the last minute. This was fascinating. When I did see the title, I was like, what? So I didn't know that my tongue at rest actually touches my upper palate and my teeth at the front. That is an eye-opener. Thank you so much. But what should we expect when we swallow? Because you mentioned that also we should drink something or swallow. Mm-hmm. Where should the tongue be?
So, hello. So can you hear me?
Yes.
Okay. So the way the tongue works is complex. The tongue just doesn't go like I'm flicking my wrist. When the tongue is moving, depending on what you are swallowing, it always creates a vacuum so that the whatever it is you are swallowing goes in one direction. So unfortunately, for people who have their nasal blockage, they have problems with swallowing properly. So when you swallow, your tongue should sweep everything from the roof of your mouth. Like you have something. Let's say, let's say you're just drinking water. Okay, this is a mug in my hand, and I'm doing this. There is a way the tongue seals the roof of the mouth so that the water or whatever I'm drinking will not flow outward. It will only flow in one direction, the direction of the back. It will go towards the throat, where we call the oropharynx. And when it gets there, gravity will take hold of that, and it will pull it right down into where it's supposed to go. Now, if I'm about to talk, at the same time when I'm about to swallow, and the airway opens at the voice box area, the airway opens at the wrong time. There's something we call epiglottis, which is at the back of the tongue that is like a flap that blocks the opening of the airway so that anything you are swallowing will not go in the wrong way. So now if you are talking and when you want to swallow at the same time, you are likely going to swallow in the wrong direction. And that's when people start choking. Sometimes we choke on our own saliva. It may not be a lot, but sometimes when it goes in the wrong place, we cough it up. So the normal way of swallowing is such that when the tongue is moving whatever it is in your mouth, whatever you have in your mouth backwards, it will seal it. It will seal the roof of the mouth such that nothing will escape to the front of the mouth. Everything must be pushed to the back. And the tongue works in concert with the roof of the mouth to sweep everything to make sure nothing sticks to the roof of the mouth that's supposed to go into the stomach.
Thank you. Thank you so much. It makes a lot of sense that when one has something wrong with the tongue and it's not laying the way it should, that it would block the airway when they sleep. I can see that in my head, and leading to obstructive sleep apnea. And we all know the health challenges that come with that. You know, obesity, respiratory problems, the list goes on. It's just not a good thing. So really my question is this. So when we see people with, symptoms of sleep apnea, even snoring, we send them for sleep study. During sleep study, the tongue is not evaluated. It is, how many times you stop breathing, that is monitored, if you're getting oxygen in your brain and stuff like that. But the tongue is not considered. Why is that? Because this seems to be very important.
Well, I mean, that's a $1 million question. I think it's all about understanding. The basic understanding that sleep doctors have about sleep is that there's tongue and it falls to the back. And there's nothing else to study about it. You understand? Because it's like a physical object that is blocking, and then all you need to do is just move it forward. That's all. But we have found out that even when you treat a patient and you do not train them on how to position their tongue at rest, they will still have problems. The positioning of the tongue affects the arch dimension, that is the arrangement, the alignment of teeth. If your tongue is in the wrong position perpetually, your teeth will become disorganized. So the tongue has a major role to play in the architecture of the upper jaw, the architecture of the nose, the architecture of the lower jaw, where the teeth are at rest and when they are functioning. If they are not all working together, there will be always chaos in the mouth. Now, one thing you have to also remember is this. If you ever beat your tongue, let's say you really love this pizza. It's so hot, it's sizzling, it's so beautiful, it's smelling so good, and it's your favorite pizza. And you put the slice in your mouth and the first bite, and you went wham on your tongue. Oh my gosh. Now, think about the pain that occurs right there at that moment, and you will not be able to chew properly from that point on. Now, wait until 2 days after, and that place is swollen and tender. You'll find out you can't even swallow properly and you can't speak properly. So the tongue is very, very valuable and very important in our daily function. And so we must respect that tongue.
So I have another question for you. I'm sorry. I think I'm loaded with them tonight. What about those people with large tongues? I've seen it.
Mm-hmm.
The tongue is just large. An exam, you're like, wow. How do you handle that? You cannot decrease the tongue. You cannot debunk it. Are you going to do surgery to reduce it? What are you going to do? It's forced. And, I've never seen somebody with large tongue that does not complain of sleep issues.
Yes,
Sleep
you're absolutely correct. Yes, you cannot do surgery to reduce the tongue unless there's a mass in the tongue. Like we have what is called ranula. We have, ranula is a disease where the tongue is so swollen, and when you look under the tongue, when you lift the tongue up, it looks like the belly of a frog. And that's what ranula means. It just means the tongue that is swollen that looks like the belly of a frog. Sometimes it's as a result of the blockage of salivary gland ducts. And then the salivary gland ducts are blocked, and the fluid that's supposed to come out is accumulating and is causing the floor of the body of the tongue to swell. If you have lingual thyroid, is another condition where the thyroid that is supposed to be in the neck starts forming in the tongue, but if it doesn't descend to the front part of the neck, it grows in the back of the tongue and creates a mass. That can cause the tongue to look like it's bigger than normal because an extra tissue that's supposed to be in the neck that is inside the tongue. That would need to be either surgically removed, but before that is done, they must make sure that there is thyroid tissue somewhere else. Otherwise, if there is no thyroid tissue, that patient will have complete absence of thyroid gland, and that is not very good for normal health. Yes, now that we know we can grow the jaws, yes, such patients, there are not many, but there are still significant number of people. But if we can grow the jaws in such a way to accommodate. So it's just like somebody having a one-car garage that's best suited for a Volkswagen Beetle. And then you went and brought in a limo that's a stretch limo, and you want to put it inside that same garage. It's not going to work. I mean, you either just park the car outside, or you allow the car to stick out like more than even the depth of the garage. So that's the situation that we face with people that have large tongue. And the only way to help them is to try to grow the jaws. And now that we know we can do that, I think there's hope for them.
That's fantastic. And I'm looking forward to the price of that coming down because it seems exorbitant and not covered by insurances yet. Correct?
I think the problem is with the CMS, the Medicare, the federal government. Anything the government starts, not, embracing, the third-party payers also will say, well, if CMS is not considering that as a procedure that they will cover, then we won't cover it either. So, but I believe that there are things, the processes are underway whereby the Congress is being approached and all the lobbying is going on around that to make sure that sleep apnea being treated other than using CPAP is recognized. It's recognized as FDA approved. If FDA has approved some of these processes, why should the payers not pay for them? So, I think the dialogue continues. So,
that's $1 million question. We know who controls healthcare in our country. So, Are there any questions for Dr. Ajagbe? This was very fascinating. Thank you for that wealth of information.
Very welcome.
Any other questions?
Good evening, Dr. Ajagbe. That was a great presentation. Thank you very much. And just want to ask a question. If you live alone, How do you know if you snore? If you sleep by yourself?
All right. Actually,
excellent question.
yeah. Actually, is this Miss Ogbebo?
Yes.
Okay. Thank you for the question. Let me just say quickly. Yes, there are ways by which you could. I think there are some apps now that allows you to use your cell phone to record yourself when you are sleeping. You may have to buy an accessory that you can connect to your phone, and some of them may actually be Bluetooth compatible. I know I have one that I think is by one Sleep Well manufacturers. They make some devices for sleep, and they have this device that is like a dish, a very small circular dish that you connect to your phone, and overnight you actually activate the app, and then it will monitor your sleep through the night. And when you have that, you'll be like, man, every time you moved, everything you do, you will hear it. You will see the plot. The graph will show you what your activity was during the night.
Thank
And
you.
then and it will give you a summary of your sleep, the quality of your sleep, or whatever it is, and so on.
Yeah, so you're right. Thank you very much for that. You're right on the morning where you said that if you open your mouth, if you breathe through your mouth, you have mouth odor and you have all kinds of dental issues. So what about mouth taping? How is that happening?
Okay, so for those who do not have problem with their nostrils, but habitual mouth breathers, you have to train them to use their nose.
Okay.
Because if they don't use their nose, their adenoids and their tonsils will always continuously be enlarged if they are mouth breathers. And that causes more of the airway blockage and swallowing problem and actually speech problem. So we must train the individuals to breathe through their nose. And one of the ways to do that is to tape their mouth, their lips. Okay. So they don't have habitual parting of their lips for them to breathe through to the mouth. You don't do it for extended period of time. You just begin to caution them and let them be aware that they don't have to breathe through their mouth because their nostrils are not blocked. But if somebody's nostrils are blocked, you cannot tape their mouth, or they will not be alive. So, so we have to maintain that balance. So it's only for those people who normally just have their jaws apart, because first of all, their tongue is always in the wrong position because they have tongue tie or they have very narrow and deep palate. The roof of the mouth is very deep and is very narrow. So the tongue cannot go up there to rest. If that's the kind of situation, you cannot just tape their lips. You have to address the underlying cause. You have to go to the root of the problem and say, okay, what is really causing this individual to be like this? And once you find out the problem, that problem, once it's addressed, will automatically cause the mouth breathing to dissipate. But yes, you're right. There are some children, they don't know that they are doing anything wrong because they just breathe through their mouth. It's like a lazy approach to breathing. And they breathe very shallow. And most of the time, those children will have recurrent lung problems. They will have asthma. They'll be more prone to allergies. So we got to address that if it's just a habitual thing. And help them tape their lips, maybe 5 to 10 minutes each time, and watch them. If they still going back, you tape it again and you watch them when you remove it and see if they are complying now. Once they begin to comply, then you don't do the taping any longer.
So in other words, you cannot continually use tape your mouth to sleep, because some people say that when they tape their mouth to sleep, they sleep better. So how is that?
Yes, if that is the case,
yes,
the root cause must be diagnosed first.
So what about if it's sleep apnea?
Now, if it's sleep apnea, it means if it's a central sleep apnea, which means it's occurring in the brain, not a physical obstruction. That is a problem that has to be addressed in a central way. That is, a neurosurgeon, a neurologist, and a neurosurgeon, and the sleep medicine people can work together on addressing central sleep apnea. But if it is physical obstruction by the tongue, at least we know that the standard of care now is CPAP for severe, sleep apnea. People who are compliant with the use of CPAP get better. They still get enough oxygen, but the root cause is not addressed. That's the problem with that. Now, if the nose of the individual who has sleep apnea is not blocked, but they are breathing through their mouth, yes, you can encourage them to breathe through their nose by taping their mouth. And if they can tolerate it through the night, perfect. It's perfect. But if they cannot tolerate it through the night, you don't want to err in that direction where they're going to hurt themselves long term. So everything must be, evaluated properly, assessed properly, and then the underlying cause be managed appropriately.
Okay, one more question. Sorry. If you're using the sleep apnea machine, and you're still breathing through your mouth, how does that help?
Well, when you are breathing through your mouth and you have sleep apnea and you're using CPAP, it only means your nostrils are either partially blocked or completely blocked. And that is why they now have cannulas. So they have cannulas that you can wear just on the nose, or a nose mask, rather than the one that covers the mouth and the nose together. So, in fact, I went to CVS, I think last week, and by accident, I just saw the display of all kinds of facial masks that they are now selling that you can buy, anybody can buy. Now, it used to be supplied by those manufacturing the CPAP machine, but now they have all the accessories. Now people are manufacturing it and selling it by third-party manufacturers. So, yes, if the mouth is still the default for breathing for somebody who has sleep apnea, it means their nostrils are blocked.
Thank you, Dr. Ajagbe. God bless.
You're very welcome.
And people who have blocked nostrils will not be able to use the nasal cannulas. They cannot get oxygen delivered through the nostrils. So that's an issue that we need to be, taken care of, whichever way, if somebody has it. So, Dr. Izugu, you have your hand raised. Kindly unmute, sir. Great.
Sure, thank you. Ajagbe, thanks for the excellent presentation on this condition. Now, one of the things that we run into significantly in managing hypertension and even diagnosing and treating it is sleep apnea contributing to that condition. Now, bringing it back to home in Nigeria, our focus has now been on managing hypertension, then diabetes and heart disease and heart failure prevention. How do you suggest what equipment specifically is easier to be used in making those diagnoses? And how could you, implement that in such an environment?
Well, first of all, thank you for the question. Yeah, for the past 7 years, I've been going back and forth to Nigeria to try to get people interested in sleep medicine. There are devices to be used that can be used in Nigeria. One of them is sleep ring. I've demonstrated it on Medical Mondays, and some members, some participants on Medical Mondays with Dr. O have used the sleep ring, and they've seen the value of the sleep ring because it will give you all the parameters of polysomnograph, all the parameters, and it's only by wearing one simple ring overnight. And so that device is available to be used anywhere in the world, anywhere there is internet, it will work. So the only thing you need will be the ring, the app that will drive the ring, that will collect the data. Because once you put the ring on and you pair it to your smartphone on the app, as soon as you put on the ring and you go to sleep, it starts working. It will record everything, details about your sleep. So you don't have to go to the lab unless you have a very severe case that you want to confirm and want to confirm the brainwave and all of that stuff for whatever other reason. But if it's just to diagnose sleep, yes, I think everybody that is diagnosed with either diabetes, hypertension, or a combination of both, obesity, anyone whose neck size is above the normal adult's neck size. For women, is 15 and a half to 16 inches. For adults, any neck size that is above 17 inches should be at least evaluated for sleep. And that is simple sleep disorder assessment. It takes less than 60 seconds to complete that sleep assessment. That will tell you if you have excessive daytime sleepiness. And if you do have excessive daytime sleepiness, it's an indication that you do not sleep well at night. If you don't sleep well at night, why? If you don't know that you snore, and if nobody told you that you snore, it is necessary to explore whether you snore or you don't snore, whether you stop breathing at night or you don't stop breathing at night. If your score is above certain number, there is a score that assessment will give to you. And then once you see that all the questions, you answer them as 3, 3, 3, 3, 3, you know the condition is pretty more in line with sleep apnea. But if everything is 0, you know it's negative, so you don't have to worry about sleep disorder. So that's the two extremes of the spectrum. It's from 0 to 3. Anything in between still shows that there is an indication for evaluation, for further evaluation. So in Nigeria, polysomnography is a difficult problem. There's only one sleep lab that I know of owned by a cardiologist in Lagos. There's no other sleep lab that I know of in Nigeria. I wanted to set up something that would be very visible. I took some sleep rings with me, trying to find physicians and dentists that can collaborate, but they don't catch the vision. They said, nobody's talking about sleep. Nobody has sleep problem in Nigeria. I said, but yeah, people snore. Yeah, it's my, you know how they say it? They say, my grandfather snored, my father snored, even my mother snored. So me, I'm snoring. So it must be hereditary. So they don't care. But until they know there is a direct correlation, yes, they will not change. So we do have devices and tools that can easily be deployed in Nigeria. And I think with your health scheme or the insurance thing, I think we can work something out whereby this can really work well, including, if I may put a little plug here, for dental coverage for Nigerians, if we can. There's a lot of people whose heart conditions will not improve because of their oral health problem.
Indeed.
So if you are giving them all the medications from America, you give them all the medications from everywhere, and they are not improving, and you look at their mouth, and their mouth is as funky as can be, well, they need help. And the first thing they're going to tell you is, I don't have money. I don't have money for this, so I can't go to the dentist. So.
You know Nigeria as well, though.
He's in Nigeria now, and if he doesn't know Nigeria well, he has a problem. But Dr. Ezugwu, I used that sleep ring.
Okay.
I was one of his guinea pigs, towards the beginning when he did that. And it's a very simple device, very easy to use. You get up to go to the bathroom, and it accommodates for that.
Yes, it actually stops. It stops and continues once you start sleeping again. It stops where you stopped. When you use the bathroom, you come back to bed and it will take off from where you stopped.
So does it constantly run on an internet system or Bluetooth system? Because you know the Nigerian situation with the network.
It's just internet.
Okay, it's both. What it does is
you have the smartphone.
The pairing with your phone is Bluetooth.
Yeah. Mm-hmm. Yes.
So when you pair it, it's just like you pairing it with your your AirPods.
Right.
So you pair it with your phone using the app. Otherwise, you wouldn't recognize it. You would not nothing else will recognize that device. So once you have the pairing, the only time you need internet is once it stops. When you wake up, finally, and you take the ring off. Either you take the ring off or you turn it off on your phone, you would press stop. When you want to start, you press record. Just like the arrow for record or play, you hit the green arrow. When you want to stop, you press the red square and say stop. Once you stop, you need internet to upload it directly to the server.
To the cloud.
Yeah.
We'll talk more about it because this is a challenge in Nigeria as a contributory factor, to blood pressure issues. And we have to, just like we do remote patient monitoring, we have to figure out other modalities by which we can put this in place. So we'll talk offline about it. Yes, thanks a lot.
I have ideas. We'll talk offline. I have ideas for that.
The funny thing, I was going to present to the House of Representatives in Abuja and the Senate and all of that stuff. All of a sudden, they are all running because they want to get re-elected. So all the planning of me presenting last December to them just fizzled out because everybody was talking. They have to get re-elected, though. They have to go for this. Anyway, but
it was just wrong timing. So there will be more time in the future. Elections are now over. Swearing in will occur on the 29th, and you start again, and you'd have the opportunity.
New regime.
New regime. Yes. Thank you so much, Dr. Ezugwu.
Thank you.
Sister Rosemary, go ahead.
So, Dr. Ajagbe, thank you very much. But how can I get the ring? I would like to.
Well, I have the ring. I have the ring.
No, Sister Rosemary, don't worry.
Okay.
We'll talk about
You'll get it.
All right, thank you.
Okay. So you have another question?
Yeah. A friend of mine had insomnia, and then she went for sleep study. The whole night she didn't sleep, but they told her that she had sleep apnea. How true is that?
That's a questionable one. If somebody didn't sleep at all,
I don't get that one. No.
I know the whole night. So
I will question the diagnosis of sleep apnea.
Thank you.
Okay, that sleep test needs to be redone, and the ring may be better. Some people cannot sleep when they're not in their own bed. when they're in a different environment. I know people who, when they travel, because it's a hotel bed, they don't sleep. They don't rest till they come back home. So for people like that, the ring is just perfect because you can do it in the comfort of your own bed.
Yeah.
And that may work
Mhm.
better for her.
Okay. Thank
And
you.
in addition to that, it's also been documented that many people, when they go for polysomnography, that is, go to the sleep lab, the moment they start hooking them up with all these cables and all these leads and all of that stuff, they are spooked. They become so worried and they can't even sleep through the night. So they become restless, and it's not because they have insomnia, but because, similar to what Dr. O just explained, that what is all this? In fact, their blood pressure will be going up because they think they're about to die. Some of them will feel that way. This thing, it may kill them. So yes, sleep ring is a very non-invasive procedure, and it is in the comfort of your own bedroom. Once you lay sleep, it starts working. Once you press record.
Thank you.
Thank you.
I have a question in the chat box. It says, thanks, Dr. Ajagbe, for educating us tonight. What do you do if you wear mouth appliance for sleep apnea and it chokes you from time to time? That's a
Well,
serious.
I don't know what that.
I can't even smile. It's a serious
Yes, that would be. Okay. I was going to say that I'm not sure what that device is, what device that particular one is. There are many devices that are being peddled in CVS or drugstores that people go there to just pick up and buy, and then they find out they don't even know how to use it. Because the instruction on the packaging may seem simple to whoever is doing
it
it,
says
or who is selling.
It says it's like a denture.
Okay, I'm getting there too. Whether it is like a denture or the one that is molded against your teeth, all that matters is if the lower jaw is not moved forward in that position through the night, then it's a waste of time.
Okay.
If it is,
and this is not over the counter. Dr. Ajagbe, I'm just following up on that question. Sorry. This is not over the counter. It's from a TMJ doctor. So this is from a dentist. So it's a medical device that is not over the counter, but it chokes the patient from time to time. I would say this patient you need to talk to your TMJ doctor to change the device, to reevaluate you, because you shouldn't be choking on a device. And if that, it's dangerous. So that's probably the right device for you. It may not be a bad device, but not the right one for you.
Yeah, I was going to say that's the whole purpose of the airway dental intervention. Anything that does not open your airway is not conducive to life. So you should not be wearing it. You should do exactly what Dr. O has recommended that you do. You should talk to your dentist or TMJ dentist. And if they want to insist that they've given you the best, you can seek second opinion. Always look for second opinion. Why come this thing is doing this to me? Am I wearing it wrong? Or what else am I doing? I know patients that have been wearing their devices wrong. So that's one option. That's one possibility right there. That the patient is not wearing the appliance properly, they will not get the desired results. So.
And thank you so much. That is so true. Again, the TMJ doctor will be able to figure that out, because what the doctor would do is actually have you put it on. How do you normally wear it? And that in itself will show if it's properly worn or not. But please don't risk choking from time
Yeah.
to time. You may choke one time and it may be the last time. So
Mhm.
even if you're sleeping, it's not safe. So please follow up on that.
Yes,
Please.
absolutely.
So, do we have any other questions? This has been fabulous. I've learned a lot.
What about hyperventilation? How does that go?
Which
Eh,
one?
Hyperventilation. Okay.
Yes.
Okay, hyperventilation.
Every patient that breathes through the mouth hyperventilates. The reason they hyperventilate is their breathing is shallow. They breathe with their intercostal muscles, that is the muscles between their ribs. They do not really engage the diaphragm, which is the bellow that is separating the chest cavity from the abdominal cavity. And that helps to push the air in and out of the lungs when we breathe. When we breathe normally, that's the way it's supposed to work. But for those people who are mouth breathers, they cannot breathe deeply and they cannot expel the air completely as well. So they have what we call hyper, carbon dioxide. There's an increased carbon dioxide, hypercapnia. So they have hypercapnia in their lung. That is, there's so much carbon dioxide that prevents oxygen to become exchanged. So there's a big problem. So that's why they breathe faster. They breathe shallower, they breathe faster because the body wants more oxygen. And the only way they can get more oxygen is to increase the rate of breathing. And so hyperventilation is not good for anybody's health. They will always have oxygen saturation that is less than 90%. And that is not good. Because once it gets to 80%, the brain is going to begin to shut down gradually. In fact, nobody can survive 80% oxygen for more than 10 minutes.
Do you know about Boteco breathing method? Does that work?
Absolutely. Absolutely.
Okay.
All right. Buteco breathing is a type of breathing that helps to open the nose. When you have nasal blockage, Buteco approach is that you can pinch your nose and blow. And once you take a deep breath, you pinch your nose and hold it until you have what we call air hunger. That is, your body now wants air. It wants air at all costs. Then you let go. But before you let go, you nod your head back and forth 5 times. And let go of your nose. You see if your nose is open. If it's not open, you do it again. You do it again until your nose becomes open. And you won't need to use any medication or anything like that.
Okay, would that also help for people that have sleep apnea? I hope I'm not taking up the whole thing. I'm so sorry.
No,
you're good. You're good.
Okay.
If the reason for their sleep apnea is
sorry, so not sleep apnea. What do they call it? Oh gee, sorry. Go ahead.
Snoring?
No.
Okay.
Asthma. People that have asthma.
Oh no.
Okay,
No.
so there are 2 different things.
Okay.
Boteco breathing technique is for those who have perpetual nasal blockage.
Okay.
Who are by default mouth breathers. And you want to move them from mouth breathing to nasal breathing. And so you want to open up the airway, the upper airway restriction, which is in the nostrils. It's not in the tonsils, it's not in the adenoids, it's not anywhere else, but just in the nostrils. So when you do the Buteyko breathing technique and the nasal, the nostrils are opened, then if they're still breathing through their mouth, then that's when taping helps. So now you go to taping to make sure the lips are completely, sealed for the nasal cavity to continue to work properly.
Okay, thank you.
But asthma is a different ball game. Asthma has to do with the lungs, not the nasal cavity. If the asthma is precipitated by allergy that affected the nose, as well as the lungs, as well as the throat, well, that's a different ball game. But if anything affects just the nose by itself and causes the blockage, that's when the Buteyko can work.
So do you have to do the Buteyko every day when you want to stop breathing through the mouth, or just do it?
No, Buteyko is for nasal blockage. If you observe that your nose is blocked.
Okay, so you do the
because if your two nostrils are blocked completely, there's no other way for you to survive other than to breathe through your mouth. So you cannot tape your lips at that point until you open your nostril. So Buteyko helps you without any medication to open your nasal passage so you can breathe through your nose.
All right. Thank you, Dr. Ajagbe. God bless.
You're very welcome. Yeah.
Thank you so much. Whew. Do we have any other questions? Fantastic. So I hope we've learned again tonight. I learned a lot. And I'm going to wish you all at this time, Medical Mondays moment. Oh, before I go there, Dr. Ajagbe, give us your parting words, please. And then.
Okay, well, I just want to remind all of us again that our nostrils, the roof of our mouth, the tongue, the lips, and the cheeks, they are very important in our staying well. In terms of our overall health, we need to be to know how to use our tongue properly, to know how to position our tongue at rest, to know how to swallow properly. And if we have been doing it wrong, we should seek help. And if we have problems pronouncing words and we thought that was normal, seek opinion. I don't think it should cost you a lot if you are not using your tongue properly and you seek help. Because if your overall health is impaired because your tongue is in the wrong position, because you are swallowing wrong, then you are not doing yourself a good service. So it's good when you go for your next dental checkup or you go to your physical that you at least let your tongue be evaluated. How is your tongue? Now, there's hope for anyone who has tongue tie, for instance. If your tongue is tied to the floor, or you have this big diastema in the front, between your front teeth, the chances are that you do have short frenum attachment, which we discussed last time I spoke, which I call the TOTS, tethered oral tissues, which includes the one in the front, the upper lip, the lower lip, and the tongue. And this, if they are all tied down, they can be freed, they can be released in order for you to get a better oral condition as well as overall systemic health. Thank you.
Thank you so much, sir. I appreciate you. I just want to seize this opportunity to wish everyone a very happy Memorial Day and Memorial Day weekend. Because we will not be having Medical Mondays on Memorial Day because of activities that different people would have. I'm also going to not be around. So Happy Memorial Day and Happy Memorial Day weekend. Till we meet next the week after.